admitting the last couple. So good afternoon, everyone in the UK, everyone else in the world, good evening, good morning. Thank you very much for joining us on this bank holiday in the UK. It's a really difficult talk, so may the force be with us. Thank you very much for Peter and Matthew for joining us to give us this talk. Traditionally in the UK, the bank holiday is the day to buy sofas and TVs on sale. So thank you very much for postponing all that to come into this very important talk. It's MACTEL type 2, which has an explosion of research in the last 12 or 13 odd years, which we were reading about in the whole weekend. And thankfully, we've got two world experts explaining that for us. I'm going to start off by asking everyone to introduce themselves. So Maria, would you be kind enough to start off, please?
Yes, my name is Maria Concepcion Guirao Navarro, and I am an ophthalmology fellow at Oxford University Hospital. Yeah, that's it. I think we have, I prefer the panelists and the speaker to, yeah.
Matthew.
Yeah, sure. So Matthew Simunovic, I'm a consultant vitreoretinal surgeon at Sydney Eye Hospital and an associate professor of ophthalmology at the University of Sydney. I did my time at the other place as well.
Yes, and now my name is Peter Issa. Can you hear me, or I don't see myself on the video? I don't know why this is.
We can hear you, Peter.
Okay, and do you also see me, or?
Yes.
Yeah.
Okay, good. So yeah, Peter Issa from the Oxford Eye Hospital. I'm one of the retina consultants with a interest in macular telangiectasia type 2, which I will also talk about.
We can see you're looking dashing and handsome, so proceed.
Good, good. Okay, so the typical patient is shown here, and it already makes the point that often you don't see much on fundoscopy, and patients sometimes have quite non-specific symptoms such as reading problems despite new reading glasses, and nothing is really found on clinical examination. It just needs some suspicion and some additional imaging to then make the diagnosis. And we'll go through most of these things in this session. So the first description was in 1977, as many diseases first described by Don Gass, as at that time bilateral paracentral capillary telangiectasias of unknown cause. And the last bit is still the same, it's still of unknown cause, but the other terminology has changed a bit. The first journal publication was then 1 year later, and already showed a pedigree suggesting that there is a genetic component of this disease. Then over the next 15 years or so, nothing really happened. And then Don Gass published an overview on idiopathic juxtafoveolar retinal telangiectasias in general, and differentiated different types or groups. And one of them was this MACTEL type 2. And it differs quite substantially from the other types, mainly by the fact that there's usually no substantial exudation, so there's no thickening of the retina on OCT imaging. It's more an atrophic disease. And he also suggested a staging, with the first stage being characterized by only angiographic hyperfluorescence, so there's nothing else visible on fundoscopy. In the second disease stage, there is some loss of retinal transparency. Next stage, he described these blunted venules, which are these vessels that seem to stop suddenly close to the fovea, and then sometimes you see these ectatic capillaries surrounding those vessels. The fourth stage was characterized by pigment plaques, these pigmented changes here, and the fifth by neovascular membranes. At that time, when he suggested this staging, this was simply based on fundus photography and angiography. There was no OCT available at that time. And Certainly this has changed, and therefore also the staging may change in the future. Also, neovascular membranes can happen at any time during the disease process and are not necessarily the disease end stage. They're more likely a complication in the disease course, like if an AMD patient develops choroidal neovascularization. So this just shows another few images of these different stages. This is the typical loss of retinal transparency in the stage 2. Stage 3 with these blunted vessels, and stage 4 with the pigment plaques that may start as these subtle changes. Often you have also these crystalline deposits, but that's not necessarily visible in all eyes and can also be visible in all disease stages. And then stage 4 with these more pronounced pigment plaques, sometimes with some atrophy surrounding them. And then stage 5 with these neovascular complexes. So after he suggested this staging, not much happened again for another about 12 years until 2005. And then an Australian billionaire started funding a huge study, the Macular study, that aimed at better understanding the disease and developing new therapies. And it's all organized by the Lowy Medical Research Institute, which is located in California. And they have a nice webpage where they explain a lot about the history and the different projects that they are funding. Basically, there is a clinical component which involves clinical centers all around the world. There is it involves a registry where patients can be enrolled. It aims at developing novel imaging methods to better understand the disease, to describe it, clinical trials. There's a reading center involved, and so on. There's also a huge lab research component, which has different subgroups, basically, mainly also including genetics, metabolomics, molecular research. And when this study started, until this study started, there was not much publication activity, as you can see in this graph. But then with the start of the Macular study, the number of publications increased massively. And at the moment, we are. So just about the terminology, I think over the last few years, macular telangiectasia or Macular type 2 has become the most commonly used terminology. There were many different other descriptive terms used in the past, but they are less and less used. So now I'm just going a little bit through the symptoms and retinal function in these patients. So the first symptoms they have are usually reading problems. That's already a little bit difficult because the most common age of onset is in their 50s, 60s. So when they need reading glasses, and then it takes quite a while until the health professionals understand that the reading glasses don't solve their problem and that there must be something else. Distortion is another rather common presenting symptom, but reading is the most common problem. And often visual acuity is normal, so 6 visual acuity, and still reading makes problems. This is explained by paracentral scotomata that develop, and this graph just shows that for proper reading, you don't only need a high visual acuity, you also need a sufficient central visual field, mainly in the reading direction. But in both directions, you need about 2 degrees, so 4 degrees in total central visual field to read words, but to then carry out adequate eye movements, you need at least 5 degrees into the reading direction, which is often not the case in Macular patients. This just shows what how their functional defects look like at the beginning and how they progress. So you can see the visual acuity at the bottom. This is decimal, so 1.0 means best visual acuity. And although, for example, in this case, visual acuity is well preserved and remains stable over many years, you can see the functional decline of this small paracentral scotoma that grows over time, but does not involve the very center, and therefore visual acuity may remain stable. So basically, they always read into their scotoma. And if you assess reading ability in those patients, with a normal, assuming a normal reading speed of about 180 words per minute, this is usually substantially reduced in those patients who may, for example, read 65 or 82 words per minute in those two cases, despite the fact that their visual acuity should allow a better reading ability or performance. So as shown before, so these are the same examples. So that this shows the progression of the scotomata, and what happens is that at some point this scotoma may also involve the foveal center, and this is the time when the visual acuity may then drop substantially, as in this case to 23 over 320. So these scotomata may be associated with all different levels of visual acuity. So even if you have very well preserved visual acuity, you can have you have usually an absolute scotoma in 50% of the eyes, and the same is true for lower visual acuity. There is an association of these disease stages as proposed by Gus in almost 2 decades ago. And if you have a patient with these pigment plaques, then they always have an absolute scotoma in this area. So basically, this is a fundoscopic.
Matthew, are you still with us?
Yeah, I am. Do you want me to impersonate Peter?
No, whilst Peter is frozen, maybe Maria, could you contact Peter to just ask him to unfreeze himself? Everything he's shown so far, and from what I know of MacTel, there's a predilection from happening temporally, and some of the papers describe the epicenter of that being so. Question is,
that's right,
is that,
about 2 degrees temporal.
Could you elaborate on that? And are there any kind of theories as to why that's the case?
Yeah, so the reason is as yet unknown. It may relate to, we might hear a little bit later about sort of the serine pathway and the importance of serine in the genesis of the condition. It may be that sort of serine metabolism is different temporal to the fovea. Why that might be is unknown.
Thank you. Peter, I just asked Matthew about the temporal predilection while we lost you, but please do continue.
Where did you lose me?
We lost you when you were talking about the best corrected spectacle visual acuity. There was a spectrum of it.
There were a series of bar graphs.
And we need to do something similar as at the beginning. Share the screen and the 3 dots.
Disable participation.
Okay.
Thank you.
Good. So where did you lose me? Let me see.
Go back a slide. Go
yeah?
back. There.
Yeah.
Continue from there, please.
There.
Okay.
So you're up to B.
Okay. Okay, I think for the time loss, I'll just skip the next few. Not really important. So, okay. This just shows the distribution of visual acuities of the entire MacTel cohort. So over almost 4,500 eyes. And as you can see, the visual acuity usually doesn't drop in many patients below 2200. And many patients have preserved a visual function that would allow them to read at least in one eye. Bilateral visual loss below 2050 happens in about 20 patients, and below 2200 in less than 1% of all patients. There was some asymmetry that suggested that there's a worse vision in the right eye, and this obviously could have been also coincidental finding, or could have been caused by some bias. But it was interesting that the morphological finding supported that the right eye seems to have worse disease than the left eye. Reason for that is not understood yet. Then metamorphopsia, distorted vision is perceived in almost all eyes, so over 80% of those with non-proliferative disease in every eye with neovascularization. The test is not, Amsler test is not good to detect a scotoma, because only a small fraction of those patients with an absolute scotoma do detect it. And this is likely explained by perceptual completion. So if you have a small scotoma below about 6 degrees in maximum diameter, your brain just fills up the scene with a pattern which is called this perceptual completion. Metamorphopsia always affect the nasal quadrant, and even in the earliest disease stage. So it's quite a good screening test. If it's in the nasal quadrant, that speaks for Macular type 2. And the subjective degree of metamorphopsia is not necessarily correlated with the leakage you see on angiography. Other visual acuities have also been tested in those patients. They have reduced contrast vision, reduced stereoscopic vision, reduced adaptation to low luminance. And the image on the right just should kind of illustrate what the reduced contrast vision may look like in MACTEL patients. On the right-hand side is the contrast perceived by a MACTEL patient. And it seems to be the case that with a lower background luminance, their contrast vision is more affected. And therefore, with the darker background, the writing is less visible than with a brighter background. So in summary, about symptoms and retinal function, visual acuity is an insufficient parameter to assess visual dysfunction because it may be affected only very late in disease. The typical loss is a focal paracentral scotoma that starts temporal to the foveal center. Patients have reading difficulties as a characteristic symptom. They have metamorphopsia and reduced contrast vision. So I would be happy to answer any questions on retinal function at this point, because we would then continue to the structural change.
So Peter, this is not necessarily a question, it's what's a statement and a question. So one of the roles of Muller cells is believed to be in assisting the regeneration of cone photopigments and sustaining vision in sort of photopic conditions. We're interested here in sort of examining the kinetics of cone adaptation following bleachers. And we're testing it specifically in MACTEL patients. Do you have facilities in Oxford to contribute patients? I.e., do you have anything that will do dark adaptation?
At the moment, well, I think you do it focally with the MetMod, or what do you use?
So we're using a MON-CV perimeter with two different wavelengths, 480 and 640.
Yeah, I think I'm not sure where we are with this. We had ordered one, but then there are different versions of it that allow you to do different things, and I'm not sure what is possible with the version we have. I have to check.
Okay, yeah. So that they're customizable in so far that
Exactly.
the company is sort of willing to modify the device. And I think the one that we bought there, they've given it a specific name. I'm not sure that it's called the Sydney Mons EV1, but it's got some sort of tag applied to it, something like the Research Mons EV1.
Good. No, it's a good point. This is one of the obvious questions to clinically study the involvement of the middle cells because of the.
Yeah, it might be an early sort of functional marker potentially.
Yeah, good point.
There are no questions so far.
Another point is what's the percentage of patients that have stage 5 disease and get CNVM? And the visions that you were alluding to, the 20/200, is that due to eccentric fixation from photoreceptor loss, or is it just the stage of?
So in the Macular study, it's about 10 to 15% of all eyes that have a neovascular complex. It's not a choroidal neovascularization. It's from it originates from the retinal vasculature usually. There's some discussion going on at the moment about retinal choroidal anastomosis formation and stuff like that. But and if you count those in, and then the number might be much higher. This is also at the moment being investigated. So, but the classic choroidal neovascular complexes are found in about 10 to 15%. The low vision patients. Sorry?
Wasn't there some histopathological evidence from an excised membrane that it was retinal? It was from some time ago.
Yes, there's an old paper where some surgeons removed a membrane, which is not a good idea because it's from the retina, exactly. But the question is rather if you ask about how often does it happen that they form neovascularizations, there may be a yet not well described form of neovascularization, which is a retinochoroidal anastomosis that doesn't lead to a lot of leakage. And if that is also seen as a neovascularization, then the number of eyes that have neovascularization may be much higher. Okay. So, yeah, it's as I said, under.
We are losing Peter. Okay.
So again, Matthew, whilst Peter's
frozen again.
So the question really I have is presumably that from stage 1 to 4, majority of treatment, or all type of treatment, is sort of supportive. There's no, I mean.
Yeah, sure. So lots of things have been explored in the past that sort of in hindsight seem like bad ideas, such as laser, PDT, anti-VEGF. As one of my colleagues, Dr. Hunya, always says, when you've got a hammer, everything looks like a nail. But certainly there's some reasons why you would not want to inject anti-VEGFs. And they don't seem to be particularly helpful. Peter will probably elaborate on this a little bit later. Certainly, they're best left for patients who in stage 5 have choroidal neovascularization or neovascularization.
So the question I have basically in terms of follow-ups for these patients, I know you're alluding to investigations, but where do you stand in terms of how often would you follow these patients up clinically? So the frequency of follow-up, what are you doing for those patients at that follow-up in terms of investigative modalities? And actually the purpose of those follow-ups, are you mainly gauged by the symptomatology that he was alluding to, the metamorphopsia, etc.?
Yeah, sure. It depends a little bit on the context in which you're seeing the patient and also what stage of disease they have. So by way of example, if you have a patient who has neovascular disease, you might be following them up quite closely, initially every month whilst they're undergoing loading doses of anti-VEGF, and then perhaps adjusting it via a treat and extend protocol. The other patients, in Sydney, they're perhaps followed up a little bit more closely in the sort of the university clinic for the reason that they're taken part in studies, including studies of CNTF implants, which maybe Peter will touch upon a little bit later.
And do you use OCTA for follow-up, for example? Do you use OCTAs for follow-up or in this disease? Do you think they are useful or?
Look, I guess case-by-case basis, but there is definitely a role for that in this day and age, definitely. So in the older papers, you know, they're relying very much on fundus fluorescein angiograms in the diagnosis, and indeed in the classification. Stage 1 relied upon it. You know, I guess as a general rule, we're performing fundus fluorescein angiograms less and less these days.
Mm-hmm.
Peter, our question was in terms of the frequency of follow-up, what you do for the patients on the day of the clinic, and the purpose of the follow-up, particularly as treatment is geared towards stage 5 rather than the earlier stages.
Yeah. So first, have you? Sorry for losing connection. I don't know why.
That's okay.
Did you hear my answer on your question for the low vision patients, why they have low vision?
Yeah,
did you hear that,
yes, we did.
Yeah, okay. Now follow up. There are several reasons, right? One is the neovascular complexes that they develop are often not very symptomatic. So we picked up some that had no symptoms and coincidentally were found. Obviously, you could argue, well, a yearly follow-up doesn't really help to detect them when it happens 2 months after you saw them last time. But yeah, that's one thing. Second is to inform them on new developments and in terms of research. There are always new opportunities popping up for those patients. There's the Ctf trial going on at the moment, for which we recruited patients, and they had to have a very specific retinal appearance to be included. Yeah, these are the main reasons clinically to why it makes sense to see those patients.
We're very keen to hear a little bit more about the CNTF, so please continue with your talk. Good.
So next is about diagnosing the disease. I just heard from Matthew about what he said about OCTA. I agree that fluorescein angiography is not really needed to make the diagnosis. It's usually non-invasive imaging modalities. And I'd like to talk about a few of them. So this just summarizes again what you typically see in these patients. And as you can already see in this overview, OCT always shows changes at every disease stage, even when fundoscopic changes are only very subtle. What is very peculiar about this disease is that there is a temporal epicenter. So the area temporal to the foveal center is always involved initially, and if the entire area is affected, we call it the Macular area, then the temporal area is usually shows the most progressed disease stage. And this just shows the typical findings in these neovascular complexes. What is quite interesting is that often, even if they show bleeding, like in this case, there's very little edema, very little leakage. One of the most striking findings is that patients lose their macular pigment in the very center. And this is a post-mortem eye with the usual yellow dot that you see in the retina. You can image those yellow dots with the so-called with different technologies, and one is the so-called 2-wavelength autofluorescence. Which shows you the distribution of macular pigment. And this is normal, as shown in this case. In macular patients, first lose macular pigment here in the temporal area, and then more and more so, and eventually it involves the entire macular area. And on a post-mortem eye, you then see this ring, or may see a ring of macular pigment, but in the very center, it's lost. It looks very different to a normal eye.
Perhaps, Peter, you could speak to supplementation with lutein and zeaxanthine in this patient group.
Yeah, okay, perhaps this first. So if you give those patients a supplementation, the macular pigment increases only where it was already present. So for example, if you take G, the ring would enhance, but there would be no accumulation of macular pigment in the center where it usually should be. So there were 2 or 3 different studies with supplementation, and they both showed the same. So it never, you cannot increase macular pigment where it's been lost, basically.
Sorry to ask another question. Why do you think it's lost, Peter?
Yeah, so
we don't. It's one of those other things that we don't really know. I guess we don't even know why we have macular pigment. So
yeah, it's a tough question. So perhaps the simplest answer may be that you need Müller cells to accumulate macular pigment.
Sure.
And if this function is lost because the Müller cells are either dysfunctional or lost, you might not accumulate it anymore.
Mm-hmm.
It doesn't explain why it then may accumulate more around the macular area.
Yeah.
But it's one possible.
It could be, I guess, a combination of things. One of the theories that we have it is sort of it mops up free radicals. So it may be that it's sort of dealing with some sort of metabolic process that's associated with the Müller cell loss. Who knows?
It would also not explain why it accumulates then around the macular area.
No, it would not.
Yeah. Yeah. One of the many unknowns.
Yeah.
Just about this technique, very briefly, macular pigment absorbs light, blue light, as shown here in this cross section, that where blue light is like used to illuminate the section, and green light is hardly absorbed. So as shown below, if you subtract those 2 images, you get you see the distribution of macular pigment. You can do the same with autofluorescence images, and the subtraction image then shows you the distribution of macular pigment. This just shows the variability in normals in the top row. So the overall amount may vary substantially, but the pattern is always the same, with the accumulation in the very center, and the number 1 to 12 show you the different patterns that may occur in MACTEL patients. One of the findings associated with this loss of macular pigment is an increased reflectivity when you use blue light to take an image. So this is with the confocal system, but you can see the same changes with the fundus camera. And if you just take the blue light reflectance image, you see an increased reflectivity in the area where you have lost the macular pigment. This area is usually larger than the area that is affected by vascular changes. And this led at that time to this hypothesis that it's not a primarily vascular disease, but that other things go on beforehand, and that the vascular changes are rather secondary changes. Because blue light is also usually used for autofluorescence imaging, the autofluorescence images are also affected by the loss of macular pigment. And where the macular pigment is lost, you usually see a higher signal than what would be expected. So in a normal autofluorescence image, you always have this dark spot in the middle, which is due to the absorption of the excitation light. Can you still hear me?
Yes.
Yes. Yes.
By the absorption of the excitation light by the macular pigment. And if the macular pigment is lost, you lose that dark spot, which you can see in all the different images on the right. I'll just skip this for the time. So, and for those reasons, because the loss of macular pigment is such a characteristic change in macular patients, and because the loss of macular pigment affects the appearance of autofluorescence images, autofluorescence imaging has a very high sensitivity and specificity to diagnose macular patients. So, and this may be more sensitive than any of the, for example, OCTA imaging modalities. So in my view, with the combination of OCT, blue reflectance, and autofluorescence imaging, you can most likely diagnose close to 100% of all patients, and possibly even, it is even more sensitive than angiography. This just shows different autofluorescence changes. So often you can also see these ectatic capillaries quite well on the high resolution images. Or sometimes like a viteliform lesion, an increased autofluorescence in the very center. Good. So the other imaging modality that is very sensitive for the diagnosis is OCT. A just shows a normal case, a normal retina, and B, a very, very early disease stage of macular type 2. So these patients are usually asymptomatic, and these changes are usually only found in fellow eyes of patients who have a more advanced disease stage in the other eye. And one of the earliest changes is an asymmetry of the foveal dip. So the foveal center is here, where you have that elevation of the EZ line, but the thinnest area of the fovea is just temporal to this center. And this is like most likely one of the earliest changes. This then gets lost later on when leakage develops in the inner retina, because then it thickens again. And the hyperoreflective cavities that most people know as a typical sign of the disease usually develop a little bit later. Then this just shows disease progression. The inner retinal spaces usually don't have any significant functional effect, but the outer ones are obviously a loss of photoreceptors and are associated with absolute scotomata. They then later collapse, and which then eventually results in an appearance like this, where the inner retina is kind of attached to the RPE.
Peter, sometimes these patients are referred to surgical retinal clinics, even in Oxford.
Yes.
What's your experience of performing surgery on these patients?
Well, I wouldn't know why you would do surgery in those. You mean the macular holes?
Macular hole. Pardon?
Yeah. I guess you're talking about the macular holes, right?
Yeah, sure. So sometimes patients are erroneously referred, and they shouldn't have surgery.
Yeah.
Yeah.
I mean, everyone only has limited own experience because of the low number of patients, although I think they might be much higher than we think. But there are a few large case series, and we also reported some in a recent paper. And the natural history of those macular holes is usually quite good. So they don't change much, let's put it that way. And their visual acuity may be much better than in the classic macular hole, because the macular hole is often a little bit decentered.
Yeah, yeah.
Also,
so
they don't close as often as normal macular holes.
Yeah.
And the visual potential of those eyes is usually limited by atrophic changes surrounding the macular hole.
Yeah, I've not really seen anything that convincingly demonstrates that there's a likely benefit to closure either, apart from making the scan look better, which you can of course show to the patient.
Yeah. There's a large retrospective review of quite many cases from a large private American practice, and they made exactly the point that you just mentioned. That that the natural history is not worse than if you did surgery.
Yeah.
Chaps, Matthew's made a good point there just now, as just for our audience sake, the differential diagnoses, including macular hole. Could you just elaborate a little bit more about differential diagnosis, perhaps tamoxifen, retinopathy, etc., etc.? And what should
tamoxifen retinopathy is very hard to distinguish. Possibly, it's not possible to distinguish it. So there is a higher number of patients with tamoxifen use in the MACTEL study. The reading center has not highlighted them as somehow different from others. My personal view is that there might be a tiny bit more central changes in the tamoxifen patients than in those without tamoxifen use. Why the phenotype is so similar is not clear. So there are different possibilities. One is that it's tamoxifen use just triggers manifest disease in patients who are already at risk of developing MACTEL via an unknown mechanism. It could be a completely independent pathway that results in the same phenotype. Yeah, it's difficult to know. I think sex steroids in general may play a role because there seem to be also more patients with lower sex steroids level, for example, who have MACTEL. But yeah, it's also something that is not really understood yet. Phenotypic differences, I think, very, very, very difficult to make a hard cutoff between tamoxifen retinopathy and MACTEL. Yeah.
Thank you.
And with macular holes, differential, it always makes sense to look at the other eye and always be suspicious if the visual acuity is too good to what you would usually expect in a patient with the same size of the macular hole, because it may then be slightly decentered.
Excellent tip. Thank you.
Yeah, this just shows the dysfunction. So basically, if the outer retina is lost, obviously you have a scotoma. The inner cysts don't really do much. And in summary, the endoscopy may be pretty normal. It may show very subtle changes. One of the most characteristic changes is the loss of macular pigment, which then also is associated with increased reflections of blue light and increased or changed foveal autofluorescence. And the question is if the OCT may be a gold standard in the diagnosis of the disease, because it seems to show very early changes. Good. This just is a little add-on on the morphology. This just shows again the same what I discussed before, the loss of macular pigment in the center and the ring with the macular pigment in the MACTEL eye. And these are just control eyes. And immunostaining of those eyes usually show the loss of markers for Müller cells in the macular area. That is the MACTEL area, basically. And this is just another eye where histology was performed. In this eye, they looked at a few different markers, markers for cone photoreceptors, so cone optins, and they are still present in areas where you have that loss of the EZ line. But what is quite strongly associated with this loss of the EZ line was a loss of the markers for rods. So rhodopsin is lost in that area. Good. Any questions about structural changes? No other questions?
Not so far, no.
Good. Then macular genetics is an evolving field. Basically, all patients who have a monozygotic twin that have been reported so far, in those patients, the monozygotic twin usually also has MACTEL. In most cases, it's been reported as pretty similar to the index patient, but we've seen one monozygotic twin also had MACTEL, but but so mild that she was asymptomatic. There seem to be other factors influencing the disease presentation that need to be added to then have a full-blown phenotype. So there are a part of the Macular study is to also examine family members, and these are just a few large pedigrees that show that it seems to run in families, but there's no consistent an inheritance pattern. But if we assume that it is an autosomal dominant inheritance, so using an autosomal dominant model with reduced penetrance, basically, then it seems that those who would have the mutation with the reduced penetrance may have an about 1 in 2 risk to develop the disease. But this assumes an autosomal dominant inheritance, and it may be more complex, it may be recessive, but it may also be just a complex disease like AMD, where some patients have mutations that result in a severe effect on developing the disease, or just have a severe effect, and others need more additional factors like aging, hypertension, diabetes, other factors that contribute to developing the full-blown disease. So with this idea that it's a complex disease like AMD, there was also a genome-wide analysis performed very recently, and this showed 3 different peaks, and 2 were implicated in the glycine and serine metabolic pathways, and another one not so well understood. But there's increasing evidence that the glycine-serine pathway is one of the main pathways that contributes to the development of the disease. And an additional metabolomics analysis in the same study found that glycine and serine levels were significantly reduced in patients with MACTEL compared to controls. So it seems to be a systemic disease. Again, similar to AMD, where dysregulation of the complement pathway and overactivation, basically systemically, may be measured in patients with AMD compared to controls. Again, similar to AMD, if you think about the history in the AMD research over the last 2 decades, the association with complement, with mutations or polymorphisms in genes that code for complement proteins was discovered in the early 2000s. And then patients with severe mutations in, for example, complement factor H, were also found to develop an AMD phenotype, but earlier than the typical AMD patient. And in a similar way, you could now approach MACTEL. So for example, if you know the pathway, for example, serine glycine pathway, you could look for other rare diseases that are defined by mutations in this pathway. And one is so-called hereditary sensory and autonomic neuropathy type 1. Never seen a patient with this, it's very, very rare. But those patients are defined by low serine levels, which has a monogenic cause. And these patients were then examined or underwent a detailed retinal examination. And in many of those patients, a typical MACTEL phenotype was found. And again, in the same study, they looked again at serine levels, and they were again lower, 20% lower in MACTEL patients than in controls. And a downstream product from having low serine levels, which is the production of these deoxysphingolines, they seem to be higher in MACTEL patients. And these compounds are known to have neurotoxic effects also in the central nervous system. So all these pathways seem to slowly uncover, and their understanding may then lead to new therapies. For example, giving serine might be a therapeutic option for MACTEL patients. And such approach has already been tried in patients with HSAN1.
So, Peter, that was a very interesting paper, I agree. So it was interesting that I think we've had 13 patients with HSAN who was studied, and 9 of them had typical features, but they thought that the remaining 4 had some sort of early features, and they were the younger patients. In terms of the, one of the interesting findings was that they found that evidence that serine levels were lower and the deoxysphingolipid levels were higher in patients who had concomitant diabetes. What do you think about that? Is that something
I missed that point in the paper, the association with that. You mean that there's an interaction with having diabetes?
Yeah. So the levels were even higher, and one of the things that they demonstrated in the organoid, they did an organoid study as part of the kind of the end part of the paper, and there was some suggestion that fenofibrate may kind of rescue the cells or prevent damage in the context of sort of the presence of deoxysphingolipids. And the CNTF implant may work because it actually is producing serine, of course, as well.
I mean, there was another interesting, very recent publication in PNAS where they came up with the idea that the low serine levels result in a mitochondrial dysfunction. So that might also be a link then to the diabetes. If you have, a reduced metabolic performance of mitochondria, that then also might obviously result in diabetes, like in the mitochondrial diseases. And I think that's a very interesting point. I've seen recently 2 patients with mitochondrial disease who also have MACTEL. So,
okay, and that they also in the animal study where they had them on a low serine diet, they found that that they had evidence of a sensory neuropathy as well. So I guess that's the next thing that people will be looking at in MACTEL to see whether it's actually in fact a systemic condition of the nervous system.
It's complex. I mean, if you ask them, it's difficult to measure everyone properly, but if you ask every patient, there are some who have sensory problems, but the vast majority doesn't. It's complex again. Good. I think the next is now therapy. How much time do I have left? How much time should we spend on this?
I'd say about 10 minutes.
10 minutes, okay. Well, very short. Everything has been tried that has been tried otherwise for macular disease, and everything has been shown not to work. So laser, PDT, surgery, and injections. Obviously, there's a question mark because there's a morphological effect, and you could first distinguish between non-proliferative disease and those with clear neovascular membranes. In those with membranes, injections have an effect. So as shown in this case, visual acuity may improve, morphology improves, but it's usually a PRN approach from the beginning, like in myopic CNVs, and usually 1 or 2 injections is enough, if needed at all, because some very mild neovascular membranes can also just be observed because they're spontaneous. They may spontaneously fibrose or become less pronounced as a natural history. In non-proliferative disease, there's a clear loss of the leakage and the reduction of the ectatic capillaries, and also OCT shows thinning. But if you just wait for 3 to 4 months, so the red arrows always show the injections, and these are monthly follow-ups, it always recurs basically. You just have to wait a few months and then it gets back to where it was before. And if you then look more closely to the structure, this is a patient who receives 12 monthly injections. Although the leakage disappears, the degenerative changes, like here the outer nuclear layer loss, just continues. And there are some signs from a study we did that the neurosensory atrophy and also the risk for developing neovascularizations may also even be higher in eyes that received injections. So these are the eyes that received injections at baseline compared with their fellow eyes, and you can see they're pretty similar. Then at last follow-up, those eyes that had monthly injections more frequently have an absolute scotoma than those who were just observed. So basically, there is a morphological effect, but no clear functional benefit. And there may be a negative effect, and therefore you should not treat those patients. It remains a treatment option for proliferative disease, but only with very few injections. So now to the Ctf trial. There was a phase 2 trial that is also already published that suggested a benefit with regards to the progression of the neurosensory degeneration in eyes who were treated with this device that secretes CNTF. And it's quite a clever idea. It's a semi-permeable membrane, which is sealed on both ends, and it includes genetically modified cells that produce CNTF. This device is then implanted into the eye at the pars plana. Quite a straightforward surgery, and then over years produces CNTF and releases it into the vitreous cavity. The idea is that the semi-permeable membrane protects the cells from access of the immune system, but lets the CNTF compound exit the device. So the eyes receiving sham treatment had an about 1/3 greater progression of neurodegeneration than the CNTF treated eyes in this phase 2 trial. And for this reason, the phase 3 is underway now with the aim to include more than 200 patients. Recruitment is virtually done. And we will know more about the results in approximately 2 years, two to 3 years. So summary, Macular type 2 is most likely not as rare as we previously believed. It's potentially quite common due to asymptomatic occurrence. There's no good data really on the frequency from population-based studies with high-resolution imaging. The epicenter of the disease is always temporal to the foveal center. And the functional changes include these paracentral scotomata, distorted vision, reduced reading ability as an early symptom, and for relatively long periods, preserved visual acuity. Retinal imaging, so ophthalmoscopically visible alterations may be absent or very subtle. Diagnostic gold standard fluorescence angiography may be questioned. I think we don't need it anymore to make the diagnosis. The typical findings are atrophic changes in the OCT imaging and increased blue reflectance due to this loss of macular pigment. And therapy for proliferative disease, one can consider anti-VEGF treatment if it's not very mild. And for non-proliferative disease, no therapy with proven benefit, and CNTF is under investigation. Mm. So there are many open questions, which I just put on the screen, I think. Sorry. And yeah, you can ask more questions now if time allows.
There is, well, one question from James Leon. Is the question is for Peter, Issa, and he says that, well, Matthew Simunovic mentioned loading dose and treat and extend regimen for neovascularization, whilst your approach was more a PRN approach, and the risk of worse atrophy with monthly regimen. The question is, are there situations where treat and extend is recommended in your view with regards with anti-VEGF?
I would never do it. We might disagree on this. It's just based on the findings that there is very low patient numbers, but there might be a negative effect. You want to keep the number of injections as low as possible. And in the vast majority of membranes, 1 or maximum 2 injections seems to be enough. And then they remain quiet. And many even don't need any treatment. It's also something you have to keep in mind, because they're just fibrosing, and patients don't develop more symptoms even over years. And then at some point, atrophy becomes more important for the eye than the actual neovascularization. Yeah, I would be very, very cautious with or keeping numbers very low, of keeping number of injections as low as possible.
There is, thank you very much. There is another question from Licie Wu. Are there comments on phenylfibrate as a possible treatment?
Well, Matthew just
yeah, it was mentioned in the paper by Gantner et al., the New England Journal of Medicine paper. So they mentioned specific treatments like serine supplementation and phenylfibrate, and they've erred on the side of caution, saying that because it's a complex disease, you shouldn't just charge straight in there, because you may in fact make the patients worse, and they left it at that.
Mm-hmm. Mm-hmm.
Guys, just a question from me. So with the CNTF, the phase studies that you were talking about, the inclusion criteria was 615 and EZ dysfunction. Where are we? I know you said the results are published in a couple of years, but where would you presume that these patients will be having these intravitreal plaques? In which stage of disease, and you know, where are we going with this?
So, in the phase 2, there were signs that patients with this new hypothesized form of retinochoroidal anastomosis might have less effect or even worse. But so the aim of that study now, of the phase 3, is to only include patients who have purely degenerative disease, so no signs of any formation of new vessels. And recruitment for that reason was quite difficult, because the inclusion criteria were very, very tough to fulfill. It also depends on outcome measures you have to study the effect. But I think, for example, if it would show a benefit, then you could most likely roll it out also for patients with much earlier disease, where determining an effect may be much more difficult. But for a clinical trial, you obviously need patients with that, or a cohort that is easy to follow up, and to where disease presentation can be quantified easily. And for those reasons, those inclusion criteria were so hard to.
Thank you, guys.
You can imagine once they kind of go for regulatory approval, it'll follow whatever they did in the trial, at least initially. And then in some places they'll bend the rules a bit. Probably not in the NHS, to be fair.
Matthew,
it will have to meet the cost per quality of £4,000. It was £4,000 when I was there, I think.
Any last questions or comments, guys?
Yes, there's one last question. Does anyone give supplementation with lutein zeaxanthin in cases diagnosed in early stages?
I'm not aware that colleagues would recommend that, and as I said earlier, it doesn't accumulate where it's lost.
I think what they're getting at is that, say it's very, very early, stage 1, do you think that there's a benefit?
I don't know.
I wouldn't hang my hat on it.
Yeah.
Hey, one more question from me. Peter, why do you think their retina goes grey?
No idea. We could talk about that for half an hour. So there's a paper that suggested that with retinal illumination, the graying disappears.
If you bleach it, it goes.
And I also believe in that. I tried it myself many times, and at least sometimes you think this is true.
Yeah, okay.
It's very difficult to quantify.
You could do reflectometry and sort of work out it might be sort of a byproduct of the bleaching process.
Yeah, I mean there are papers from animal models from Eberhard Srenner where they argue that changes in the extracellular ion composition may cause retinal or change the retinal translucency.
Okay.
Perhaps if the Müller cells play a role in that respect, that might be an explanation. Yeah.
Okay, so we'll bring it to an end. Thank you very much for such an interesting and a great sort of interactive talk. I guess the take-home messages for the audience: serine supplementation's good. Surgical removal of CNVMs, bad. Thank you so much for your time, and we'll catch up with you hopefully for the next talk. Thank you.
Okay, thanks very much.
Thanks for listening.
Thanks, Peter.
Thank you very much. Thanks.